So we have our continuing with respiratory system and medical terminology, digestive, and the urinary, which will help you in your first positioning classes, all of those. I added this today, so it wasn't there yesterday either. Today we're doing vital signs and medical emergencies. Tomorrow in class, we'll break out the blood pressure cuffs and do blood pressures on each other. So it's chapters 15 and 17 in your patient care book. Then tomorrow when we're on campus, we'll look over infection control, and again, we'll take blood pressures, and we'll also practice in the lab for your lab comp. That's gonna be week 4, your project lab comp. And tomorrow, after that, we'll be done. So maybe done early, I don't know, we'll see. I don't wanna promise you that you'll be done early. Aseptic, non-aseptic techniques is Thursday, and then the drug administration is, Wednesday is aseptic, non-aseptic. Thursday, we'll be back at the school looking at drug administration, chapter 22, and then our exam on Friday. Just as a reminder, I posted this for you guys. I didn't have it in the last few weeks, so our exams are worth 20% from here on out, where our first exam was only 15%, and our quizzes and everything, our homework assignments and all are 10. Then your written paper is your letter, your project is 10%, and then post-test is 5. So when you're thinking about the grade for the class, what you have right now is not with a lot of these in it, so your grade's gonna change based off of that project and the post-test. At the end, it'll bring your grade up about 15%. And then our objectives for the week are here if you want to use these to make a study guide after we get done with each chapter, whatever we went over. Like today is vital signs, which there's not a lot on here objective-wise for the vital signs. These are more for getting you ready for clinic and having to monitor that kind of thing. So a little bit on oxygen today, the tubes and the lines we're going to talk about today. So this first little bullet, and then infection control and all's later in the week. So really this first bullet's what we're going over today. That'll be if you want to take these objectives and make your study guide questions for your test on Friday. All of this is pulled from the syllabus. I know I haven't been adding it to every week for these, but you can go back for your final and pull all the bullets from your syllabus for the final exam review. Now, let's see, chapter 15, the vital sign chapter. Chapter 15 is where we're going to start. I feel like we're like almost done. This class is going by so quick. Trying to get to the book page. So again, this is all just to make you aware of things that you might need to monitor. When you go into an inpatient in the hospital, they're going to be hooked up to a machine that's monitoring their vital signs. If you go to work at a care spot type of place, we do have some x-ray techs there that do x-ray for the doctors. So Lantic, Abyssina Medical, I have a few graduates that work there. So if you go there, you're going to be doing vitals on patients. But if you work at a hospital, you're probably not going to be doing vital signs on your patients. You're just going to see their monitor if you go into the room. And you may like it, may not. Some people do like doing that kind of thing. So these are objectives that the book put out, what the chapter's all about. So maybe you have this word in medical terminology already, homeostasis, but if not, it's definitely in the chapter. Basically means that everything's balanced. We have our right blood pressure, our right temperature, our body's working correctly. If something's high or low, then we are not in homeostasis. So it's our internal data that we can collect from a patient to see if they're working right, their body is maintaining the correct things that it should be. We want to know what vital signs that we need to take: temperature, respiration, pulse, and blood pressure, and then the normal range for each of those. So there's some questions right there that'll be on your exam from those ranges that we are going to be asking you if you know what's high or low. what could happen with abnormal vital signs, how do we assess them, how do we take them, what tools do we use. And then the next section is oxygen therapy. And we have different methods for delivering oxygen, high and low flow devices. We don't deliver it, but we are going to be taking x-rays of people on oxygen, either a tank or hooked to the wall or something like that. What cautions should we be aware of? Also, we will have patients that are in the hospital that have machines hooked up to them to make them breathe, and different lines and tubes in patients, so we're going to look at that. This will be your first day of getting to look at some x-rays, so we're finally getting to look at radiographs. Looking at them and seeing these lines on an x-ray and knowing the different types of lines that patients are going to have in them. So there's a couple that we'll specifically ask you about. And complications with these lines that we have being placed when we're putting them into a patient, what could happen? So here's the first little page in the book. It's on page 166, homeostasis, blue word, bold. It's the body state. Basically, when we're in homeostasis, we're good, everything's good. But if we are in a situation where we're scared and our adrenaline kicks in, our heart rate's gonna go up, we're gonna be able to be super strong more than we normally are, we're gonna be able to run faster. So to survive, your adrenaline gets kicked out of your kidney, has the adrenal glands on top of them, so it's gonna pump some adrenal gland secretions into our body and make the heart rate go up so that we can do things faster. We also have that happen if we get sick and have a fever, our body temperature is going to spike, our heart rate's going to be a little off. Sometimes if you have problems, your respirations are going to change. So different things that we can measure. The feedback mechanism can be positive or negative. So most of the time it's a negative thing. Something bad's going to be going on to our body when these things are happening to us. So these are our measuring, what we can measure in the patients to see if they're in homeostasis: their heart rate, blood pressure, their temperature, their respirations, and electrolyte balance. We don't think about that much, but that's why they draw blood every time you go to the hospital to see what's going on with your levels. So of course, you've probably all had your temperature taken by now, coming to campus every day. This is showing the common method that they use in the hospital, which is the under the tongue. It's like a little plastic cover over the probe that we have. Now everybody's doing the thermo, no touch. So pretty much that'll be what you'll see everywhere now. So we also have a little tool to measure pulse. It's a little clip-on for your finger, and it measures your pulse rate and your oxygen levels in your blood at the same time, your saturation levels. So these are called vital signs. Blood pressure, we're gonna talk about our 2 numbers that we need to maintain. If anybody has been to the doctor, you've had your blood pressure taken, you can also go to one of those little walk-up things at Walmart or CVS and put your arm in it and get your blood pressure taken that way. Respiration rate is how many times your chest rises and falls. We're gonna look at that individual. And then other things that you could take note on if you're doing vitals is their mental state and sensor. Not a lot of places will have that as a thing you chart. If you're a nurse, of course, working with a patient, you might chart that daily, but when you're just taking up regular vitals, there's like a check-off list that you put in. It's not normally something we note. And any of the offices I've had to work at or seen with students. Normal temperature, so here's what you wanna highlight. It's also under body temperature in the book, 97.7 to 99.5. It's considered normal for temperature. Respirations, adult, 12 to 20 breaths per minute. So that's a rise and fall of the chest. We normally will take pulse and respiration together and watch, and we'll practice this tomorrow on campus. Putting your finger and measuring their pulse, and while they're thinking you're measuring their pulse, you're gonna watch their breathing. Because if you tell a patient, okay, I'm gonna count your respirations now, you're automatically, as a patient or a person, gonna hold your breath or breathe faster. So one or the other is going to happen. You're not going to breathe normal. So we want 12 to 20, rise and fall counts as 1. Child, it's a little higher, 20 to 30 breaths per minute. And then the same thing with pulse. 60 to 100 for adults and 70 to 120 for child. We're going to talk about blood pressure in detail a little bit more, but the top number is called systolic, and that needs to be less than 120. And our bottom number is called the diastolic number, and that needs to be less than 80 to be considered normal. So used to, we would teach you to convert Celsius to Fahrenheit. There's this whole formula, but it looks like we don't have to do that anymore, thank goodness. So you can be off 1 or 2 degrees, depending on where you take your temperature. It also can change, whether you take it under the tongue or at the thermal area at the forehead or under the armpit, or you can also take rectal temps. They like to do babies that way to get a more better body temp reading, but that's our normal temp. 98.6 is considered like spot on what it should be. This is kind of our things that could happen if you have too low of a temperature. You're going to be shivering. Diaphoresis could happen if you see a patient that's like clammy or sweaty. It happens if they're going to have a heart attack sometimes, or if they're really, really sick with some kind of cold or flu, that could happen. This is called thermoregulation, the body's ability to regulate our temperature. So here's the little slide that shows you the different methods that I just talked about: oral, axillary, temporal, tympanic, and rectal. And rectal is considered the most accurate. I don't know why it's, okay, that's the slide I'm looking for. Okay. Trying to see where it describes the different ways and the normal temperatures for it. We're doing temporal artery thermometers right now. I guess that's all we need to know on that. So this again has all of the, that's what I was looking for, all the normal ranges depending on which method you're using on the thermometers, but we're not going to test you on that. Just know the normal range for children and adults. Hypothermia means too low of a temperature. So below 97, hyper meaning high, is greater than 99.5. Pulse, we have a couple of places if you don't already know that you can take the pulse. So you can do it in the carotid artery in your neck. Don't use your thumb because your thumb has its own pulse. So 2 fingers, if you put it there for just a second, try to feel the pulse. That's really faint. Don't push too hard either, you'll cut off the blood flow. Try the other side, I'm not getting a good one on that side. Does everybody feel it? Something? If you don't feel it there in your carotid arteries, you can feel it in your wrists. So you'll see people taking it in the wrist. Unless they're laying down on a stretcher at the hospital and they're in a trauma, they may do it there. So we'll talk more about the cardiovascular system when you get into your patho class. We do teach the whole blood flow through the heart and to the rest of the body, including the brain and everything. So you will know this whole cardiovascular system before you graduate. It's considered a closed system because we don't want to leak out any blood. Just keeps recycling through our body. So the heart is pumping blood through the body from the left ventricle and going out. We're going to talk more about this when you get into patho again. You don't need to memorize all this now. If you remember it from anatomy class, good. but ventricles pump the heart when they contract and it pushes it out through the body. So here's our places, the radial artery, brachial artery is in the arm here, and carotid at the neck. Pulse rate, that's what we're doing when we're hearing or feeling those beats. How many are gonna beat in a minute is our pulse rate. So 60 to 100 is normal. Tachycardia is a medical terminology word. I don't know if you guys have reached it yet in the book on med term. Greater than 100 beats per minute, and bradycardia is low. So these words will be on your quiz and exam, tachycardia and bradycardia. Fast heartbeat or low heartbeat, low rate. So depending on if you're an adult or a child, 70 to 120 for a child, 60 to 100 for an adult. So greater than 100 is tachycardia. So when we have too fast of a heart rate, that's putting too much strain on our heart. So that's usually where we're more concerned than low. Anybody who takes some kind of certain crazy, we have people that take drugs and come into the hospital, their heart rate's really high, they're probably going to be suspicious of that. First thing they're going to want to do is do a toxicology on them, unless they already know they have like some kind of heart problem or something. Low heart rate's generally not too concerning unless it's like shock or trauma situation. But if you're just a little below normal on low, they're not going to be too concerned. And we want to also remember that we want to take our heart rate at rest. So I usually have you guys take your heart rate in the room, and then I have you go running up and down the stairs and come back and take your heart rate and see how it changes. So you guys are lucky you're at home today. So during CPR, you guys probably talked about that when you're doing those compressions, you're mimicking the ventricles closing and getting blood to pump through the body. We normally measure that at the carotid again in trauma situations or critical care. And we have a special thing called a pulse oximeter. That's like in the hospital, in the bed, or even when you come in to get your vitals checked anymore, they put the little thing on your finger to measure it. It's called a pulse oximeter. We also can listen to the heart with a stethoscope. This little dart ear is on and listen. That's more what the doctor's going to do or the nurse. We don't usually do that. Here's a picture of the pulse oximeter. So if you have a patient who it's not getting a good reading on their finger, they may use it on the big toe or an earlobe. Sometimes older people, they'll put it there. So it basically uses a light to measure the oxygen levels and pulse rate. So oxygen saturation, there's always going to be on this pulse oximeter a percent. That's how much blood oxygen levels that it's reading that the patient has. So if it's not on correctly, if they have fingernail polish on, sometimes that interferes with it. So we usually are going to see a 97, 99 on there or 100. If it's below 95, that means they probably need to be put on oxygen, that they're not getting enough oxygen in their blood. So it's a really small window of what's good for oxygen saturation in the blood. 95 to 100 is what we want to see there. And then we talked about breathing when they're in and out, chest expanding, up and down. That's one respiration. So when we breathe in, our diaphragm goes down. When we breathe up, our diaphragm pushes up the air out of our lungs. So that's considered inspiration. When we breathe in, it's bringing the diaphragm down, and expiration, when we breathe out, it's pushing the diaphragm up. So that's going to be important when we do chest x-rays. So we get a diaphragm down on our picture, inspiration. Here's a picture of it showing it. So the diaphragm is this muscle that sits at the base of the lungs and pulls and expands and contracts when we breathe in and out. So again, we have high or low breathing. Tachypnea, pnea meaning to breathe, is less than 20 respirations per minute. So when we're doing it, if we're doing it for a doctor's office and we're the nurse kind of person, we're going to talk about how many breaths, how deep they were, and if there's a pattern. Some people, if they're older, have lung problems like COPD or something, they may breathe a couple fast and then slow, or rasping if they're sick or something. So that would be what we would talk about with the pattern of breathing. Don't do too much on that. Just know the normal respirations and what tachypnea is. Make sure we got it in here. Greater than 20 breaths per minute, tachypnea. That's on page 169 in blue. And we're going to flip over to page 171, because I don't know if I have pictures of these on here or not. This is kind of put together from the book. We'll talk more in person too. I'm going to show you these pieces of equipment tomorrow and have you guys practice taking blood pressures. So we have, when the heart's pumping, the arteries are contracting and relaxing. So that's the measurement we're taking with our blood pressure. Diastolic and systolic. On page 171, it's in bold. The constant pressure exerted on the heart, kind of in that middle of that paragraph, where diastolic is in blue. So the pressure is the diastolic. During the contraction, the blood is ejected from the ventricles through the arteries, causing more pressure. The peak pressure, when the heart is in its contraction, is called the systolic pressure. I don't like how that's worded. And that's all they say about it. So the first number we hear when we're listening is going to be our systolic pressure. Wish they would have flipped that around. Diastolic on the bottom, systolic on the top. So that first number we're going to be listening for with our stethoscope, and we're going to use this blood pressure cuff, we just call it, because nobody likes to say sphygmomanometer. That's what the actual name is for the blood pressure cuff, because it has this little meter on it that is reading the pressures. And there's a picture on 171 at the top. So we're going to use the little pump to pump it up, the pressure, and then there's a little dial beside it, that little metal silver piece that we're going to close off so that the air can't come out. And as we're listening after we get it pumped up, we're going to slowly release the air out. Some of you have probably already done blood pressures before. As we're releasing the air out, we're watching the needle drop down on the little meter. And once it gets to around where we know the top number, the systolic pressure should be about 120 or so, we're going to watch it and it's going to start jumping. And it's going to jump in relation to the heartbeat because it's measuring the pressure of the heartbeat in the arm. So it's going to do its little jump, 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 jump until it no longer feels the heartbeat anymore. The first number we hear is the peak pressure, the highest pressure that it's putting out, and that's our top number, systolic pressure. Our last number is the lowest, or the relaxation, when the heart's no longer getting a reading on how much pressure it's given us anymore. That's our diastolic pressure on the bottom. That's our second number we hear, or the second number we record. So the needle's going to jump, and then at some point it's going to stop jumping. So you're going to watch on the little meter where it stops, and that's our second number. First number where it starts to jump, second number where it stops to jumping. And we're going to do this together tomorrow, so we'll talk about it again there. So diastolic and systolic are our two pressures. The peak pressure is systolic, the highest pressure that it's putting out. So abnormalities. Systolic, again, should be 120 or below. Diastolic is when the relaxation is happening less than 80. So the contraction and the relaxation. This is what I was looking for in the book. It doesn't describe it like that, unless it's in the reading some more. But we measure it in millimeters of mercury. That's what those numbers actually mean. We just always say 120 over 80 is good. Higher than 120 or higher than 80 is bad. The bottom number is usually more important than the top number, but we still look at both of them. Here's a picture of the cuff. And this is our little bulb I was talking about. This little dial is what controls the flow of air out of it. So once we get it pumped up, we're pumping up that pressure gauge to at least 140, 150, because we need to see it drop down to around 120 to see if it's going to start jumping there. If we have somebody we already know has high blood pressure, you might pump it up to 200 because their top number may be 150, 160 if they're having high blood pressure. This one up top is what we love. It's an automatic blood pressure machine. We just hook them up to it and push the start button and it does everything for us. But we're doing it the old-fashioned way with the stethoscope and the little meter. Sphygmomanometer. Blood pressure cuff is what everybody just calls it when they say, grab me a blood pressure cuff. But, so again, you're gonna pump it up and then release it until you see the little needle get to where it starts its little jumping. When you don't hear any sounds anymore, that's the other part of it. You want to listen as you're watching the needle jump. You'll hear before you'll see the needle stop. You'll hear no more heartbeats. So you'll be cutting off their circulation technically on their arm when you pump it up so high. You'll hear the heartbeat start, and that's when you'll see the needle start jumping. You'll see the needle stop jumping once you hear the heartbeat stop. So you're going to listen and look to make sure you don't miss it. The needle jumping is just a indicator. So our bottom one is diastolic again. That's our when no more sounds are heard, and the systolic is the top one that we will start hearing the heartbeat and we'll see the needle jumping. So we always want to put the cuff on tight, and there's a little arrow on it that shows you over the artery. So you want to put it on until the little arrow is pointing somewhere in the armpit crease area so that it's facing this way, not back on the back. Normal 120 over 80, and when you have high blood pressure, that's hypertension. Low blood pressure is lower than the 120 over 80, hypo. Again, the higher is what we look for more often than low. It's not really a big deal to have low blood pressure, but if you have high blood pressure, that's very bad because it's putting a lot of strain on your heart, and that's why it's called the silent killer. The patient doesn't know it, and they might have just a heart attack without no warning signs because they didn't know they had high blood pressure. Oxygen therapy, and that's the last little section in the chapter, talking about this thing that we all take for granted because it's colorless and tasteless and odorless most of the time. Gas. It is a gas, so because it's free for us in the air, you have to pay a lot of money for it if you're a patient needing oxygen therapy, and it has to be prescribed. You can't just get put on it because you think you need oxygen. It says it's not flammable, but it supports combustion. So we always want to be real careful around oxygen tanks. We don't want to drop them or anything because they could explode. Just remember, it is considered a drug. It must be ordered by a doctor. And because of that, we can't just hook patients up to oxygen and turn it on and, oh, they seem like they need some oxygen. They're not breathing well. They have to be prescribed it, and a respiratory therapist has to come in and set it up, or the nurse, even though not saying I haven't ever put somebody on oxygen before, but legally we probably should not be doing that because overinflate their lungs. Yes.
Okay, so I work for a respiratory company, and I know you had mentioned earlier in the slides that 95% or below. I know that, I don't know if it's because of Medicare guidelines and insurance guidelines, but we go by 88 or below. Is that why? Because of the insurance?
Yeah, it's probably insurance relation. Yep. Kevin, go ahead.
I know you said it's not flammable, but like, is this like a 100% oxygen, or is it mixed with something? Because from work experience, oxygen is highly flammable.
So it's saying it supports combustion. So without oxygen, we can't have fire. We know that. We flame the fire. So yeah, that's what it's meaning.
Okay.
That by itself, it won't burn, but we need oxygen to have fire. Yeah. And yeah, I think it's considered for, like Marcelli was asking, for reimbursement purposes, they need to be super, super low for them to get reimbursed for Medicaid, Medicare to pay for their oxygen and stuff. We just consider 95 and above that they're getting enough oxygen flow. Anything below that, we may have them put on some kind of CPAP or oxygen.
Yeah, that's really good to know.
Now, almost everybody in the ER, I don't know if it's, again, an insurance thing. If you're sick with a cold, a flu, or any kind of respiratory problems or breathing problems, they're going to put you on oxygen while you're there. That doesn't mean you're going to go home with oxygen. I know whenever I was sick last year, I had pneumonia, and I was like almost 90 on my oxygen when I was in there, and it was going up and down, fluctuating while I was there. But after the breathing treatment, everything was good. I was able to get my lungs cleared to get oxygen to work better. So hypoxemia and hypoxia are things that we have to watch out for with oxygen. We don't want to have too much or too little oxygen in the blood, because that's going to cause problems for the patient. They'll get dizzy and things like that if they have too much oxygen in their system. So that's why they are monitored and prescribed it. So here's a portable and a big oxygen tank. I've never seen one that looks like maybe that's an older model. I don't know.
That's a liquid. That's a liquid form. It's not a concentrator. That's liquid.
Yeah.
You're looking at.
Yeah. Most patients are either going to have those big cylinder tanks or these little portable ones. Now, sometimes in their houses, they'll have one that's like a plug in the wall type that they can have at their house to supply them with their oxygen. That's not, it's kind of recirculating the air, I guess, from their home. But here's what you'll be mostly seeing, these tanks that slide into the beds at the hospital. Green is the universal color for oxygen, so that's usually what color they're going to be. And there's usually a little tag on them that says full and empty, and they tear it off. So you know you don't want to grab an empty tank with your trying to hurry up and get oxygen to a patient. So there's usually a little paper tag, but rubber banded on there, so you know if it's an empty tank or a full tank. So when we're using oxygen, I don't know why we go into this if we're not supposed to be turning it on and off, but there's a little dial over here that you can turn it up to so many pressures. So most people get put on 2% or 2 on there, 2 liters per minute. And then the tubing hooks up to this little piece here, and it usually hooks through to their nose. And I hate putting those on. I always can never get them back on the right way. So I usually let the patient or the nurse do that, because I always end up not getting the loops right around their ears. But if you have a patient that's on oxygen, you should keep them on it throughout the whole procedure. So we shouldn't really have them taking it off. Now, patients hate it. Sometimes it bothers them, especially if they're not used to wearing it. So they're like, oh, somebody's getting me to go do an exam. I'm taking this off. But hopefully they keep it on. Here's one that's a delivery, oxygen delivery from the wall. A lot of x-ray rooms and patients' rooms are all going to have these straight through. And again, there's a little dial over here to turn up. It's a little ball that floats. When you get to 2, that's how much they're getting, 2 liters per minute. That's what we measure the oxygen flow by.
They just connect the tank to that?
So not their tank, just their tubing. Their tube that goes into their nose, it's a plastic tube.
I don't know why I thought they just go up there with their mouth and get oxygen.
No, yeah, just open up. So the flow meter, again, is green in color, letting us know that this is oxygen, because there are other, sometimes valves on the wall with other types of gases. So yeah, if they're bringing their own oxygen from home and they know we have a wall oxygen, they're gonna wanna use our wall oxygen to save that tank of oxygen for them to have at home. So they'll want to be hooked up to it. So these are portable that they can carry with them. They're not always as big as what we have in the bed. Sometimes they're a half of that size, a little one that they can take with them when they go out to a store. It's gonna have a flow meter and a pressure manometer to make sure it's flowing the right liters per minute and how much pressure it's being left, how much is left in the tank. That's what the pressure meter gives us. It's full or if it's losing pressure, we know the tank's almost empty. If the red line's over by 0 almost, they are gonna need a new tank soon. So we wanna make sure before we transport a patient that we have enough oxygen to last. So we wanna look at that on the tank to make sure that the pressure is at least halfway or so to make sure they make it. It should be secured during the transport. That way you don't drop the tank on the ground or anything. Sometimes there's holders in the beds. Sometimes we set them along the side of the patient's body or leg area at the foot of the bed. But usually they are in a secured place on the stretchers. All right, so here's the 2 different types of delivery devices we could have, or multiple types, but high flow or low flow rates. So if somebody needs a lot of oxygen, they're having a lot of problems breathing, they're gonna be on a high flow. Low flow, it's usually just through the nose. The nasal cannula is one method of delivering. A mask, a tent, or an oxy hood, those are gonna be more for little babies or kids, or a ventilator. So this is the tubing I was saying I didn't like to have to put back on the patient. I always end up with it wrong. The nasal cannula is probably the most common. That's what you get when you go to the ER usually. Now, if you're having a lot of respiratory problems, they're gonna step you up to this one. This is like an elastic string mask and it's got an extra bag attached to it. It's called a non-rebreather mask. So it keeps the oxygen that's being pumped in that mask and makes it a little bit forceful to go in more. This one, it can escape out the nose and come down and not go up when they're breathing in. And we do have patients who are mouth breathers that breathe through their mouth, not their nose. So this mask kind would be better. Here's the baby with the tent, the oxy hood type covering, kind of makes the oxygen go. Kids do not like those masks attached to them. So we need more of a higher flow rate with this, 4 liters per minute, because we're losing some oxygen and we have to add in humidity, which is what these big tubes are doing back in the back here, this one, and this one's a different type. The liquid is going to help prevent the nose and everything from drying out from that high oxygen that we're giving them. So it's a separate tubing from the wall, putting in the water with it or the humidity.
So are we losing oxygen when we wear these masks in public?
Good question. There's a lot of people that say we do. It's harder to breathe. It feels like we're not getting air, but we are able to breathe in. It's not blocking airflow. It's just a different, I think you're maybe breathing in more CO2 because you're breathing in and out so much. So that's the issue.
So we're gonna need portable oxygen tanks in a minute.
Yeah, maybe. Just keep taking breaths, get your oxygen cleared. So again, for us as a tech, we're not going to administer oxygen or take people off of oxygen without the doctor's consent. or a supervisor, physician, a respiratory therapist, or the attending nurse. They should be in charge of that. All right, we have some tubes that we want to be aware of. Sorry, he's like crazy about the lizards. I don't know if you can hear the dog. He's attacking. Endotracheal tubes. Chest tubes are called thoracostomy tubes, but everybody just calls them chest tubes when they have a tube in their chest. Central venous pressure lines, or CVP lines, and then pulmonary arterial lines. There's a lot in this chapter, guys. They mixed it all in with vitals. This is kind of the fun stuff because we actually get to look at some x-rays here. And this is starting on page 178. So an endotracheal tube is a placement of a tube that goes into the trachea, that goes down into our lungs so that we can breathe. So when somebody is intubated, we say we're breathing for them with a machine, or intubated. We put in an endotracheal tube. Well, we don't. The respiratory therapist or the doctor does. The tube is going to go, and this is highlightable, if you see it in the book, right here on the slide, 3 to 5 centimeters above the bifurcation. So our trachea comes down our throat, and then it splits into each lung, right and left. Anybody found it in the book? Oh yeah, on page 179. Second paragraph under the intubation, 3 to 5 centimeters is in parentheses, or 1 to 2 inches. This area of bifurcation is called the carina. I don't know if anybody remembers that from A and P, where the trachea comes down and then it splits off into the right and left lungs, is the carina. So that's an important area for us. Every person who gets intubated needs a chest x-ray to verify the position of that tube, because if they do not put it in right and they go down too low, it could go into the right mainstem bronchus. Because of the way the bifurcation is into our lungs, the right one's more straight down and then the left one takes a sharp curve off. So the right one is probably more likely, if they put it down too far, where it's going to go. And that's going to only give oxygen to the right lung. Left lung's not going to get oxygen, so it's going to collapse on the patient, and you're going to have a lung collapse if they're only breathing on one lung. Overinflation of the right. So there's a couple of x-rays in the book. And it takes a long time looking at these. I'm going to show them on the screen, and hopefully you'll be able to see what we're talking about in a minute. So reasons that patients need intubation or endotracheal tubes is going to be put on a mechanical ventilator because they're not getting enough oxygen. They're not breathing right. Their oxygen levels are not correct. They have some kind of obstruction in the airway, so a tumor sometimes pushing on it, or food or something stuck in the way until that can be removed. If they go into shock, have an aspiration, some kind of bronchial lavage that's going on that they go in and do, it's probably going to be done in the OR if that's happening, and they put them on an endotracheal tube for that to go in and clean it out in the bronchioles. All of these reasons or indications are going to require endotracheal tubes, and then we also are going to have to do an x-ray so we can check the placement. So these are x-rays that are called stat x-rays when they put a tube in, because they want to know right then, is this patient going to be okay to turn on the oxygen flow and breathe normal with the machine now. So we usually go immediately when they order a tube placement x-ray. Most places it's within an hour, but really we usually go within 2 to 5 minutes and we get the x-ray for them. Here's a picture of the tube that's in the book, letter A there on 179, the plastic tube that they put down the throat. So this picture has a lot going on in it. There's looks like some kind of tubing here, maybe from oxygen, but this white line in the middle is the endotracheal tube that we're looking at. Then we have these little clips, EKG wires all around over here, looks like spaghetti noodles. They're laying down in a bed, they're a little twisted, their clavicles are kind of shifted. You can see that they're not laying totally flat, good, straight. But we're seeing the end of that tip in the center of the circle right here. If you kind of look, you can see a black shadowy line here. That's the air in the trachea. And then if you, it's hard for me to even see it. If you look here, you can see a line coming down here and then here, like a black like a tube line. That's the bifurcation of the trachea. Where it's, see it's coming into this lung over here and right here into this lung. So it comes into a V right there. Super hard to see, guys. You can kind of see it in the book better. The splotchy black, like the white peak is the V that I'm looking at. Let's see if I can draw on here.
It's page 179, by the way.
Mm-hmm. Okay. And there's the trachea line coming in. There's that one. So this is the peak or the V shape we're talking about. This is the end of the tube tip. It's right above the carina, so it's right where it needs to be. Clear. Very faint, right there. And this one, of course, is not the clearest because of the way the patient looks. So we're going to look at another one. Let's see if we can have a better picture on the next person. So we need to know where the chest tube needs to end, about 1 to 2 inches above the carina, or the bifurcation. This is a different type of tube. So endotracheal tubes into the trachea for us to have somebody on a breathing machine. This is called a thoracostomy tube or a chest tube. That's mostly what you'll hear it called. These are into the chest, straight through the skin, in between the ribs, into the lungs. A chest tube goes in the interpleural space in the mediastinum area, and it drains out either fluid or air to create a negative pressure in the chest wall to help repair an atelectasis, which is another medical terminology word that we're going to talk about in the lung chapter. That is a collapsed lung. A pneumothorax, which is air in the lungs, so pneumo being air. A hemothorax, which is blood in the lungs. Pleural effusion, which is just the pleural cavity around the lungs. There's a thin layer of what we call pleura. It's like a thin tissue surrounding it. I always think of a baby inside the sac that protects the baby, the little thin layer of tissue around it. That's what our lungs have around it. We have 2 layers of pleura, 2 layers of tissue around the lungs protecting them. Visceral and parietal pleura. So there's 2 layers. If in between those layers fluid builds up, that's when we have pleural effusion. So fluid building up in between the layers of the pleura. So it's going to press on the lungs. It's going to look like fluid in the lungs, but it's actually the pleura, those 2 thin layers of tissue that we have, that has the fluid effused in between them. So it's like if you put 2 balloons inside of each other, and then in between the 2 balloons, fluid is pushing on one or the other. And that causes pressure in the lungs, problems with breathing, and we need to get that fluid out. Anemia is a pus pocket. So they would have to exactly put the tube straight to that pus pocket and drain it out. So any of these kind of issues with the lungs that the patient might have, we would have them a chest tube inserted. And it's a temporary thing until the fluid or the air, whatever it is drained out, and then they take the chest tube out. So most of them are going to depend on where the substance is. It's usually inserted between the 5th and 6th intercostal space or in between the ribs. And then we say it goes in laterally and mid-axillary line. So, that's a weird wording. So moving in across the body, somewhere near the axillary area or the armpit area. It could go up to the 4th rib or as low as the 8th. It all depends on the patient's area of interest of where they're needing that tube to drain. So we do a chest x-ray for a chest tube. This one's dark. Right up here, this weird line coming in. It's really high. See how it's coming out the body here? So it's draining out to fix this upper lobe of this lung over here. So this is a pneumothorax where all the air is leaked out of the lung. So pneumothoraxes are really hard for us to see. You guys, thank goodness we're not radiologists, but I'm gonna explain it a little bit. This is a super dark x-ray. See how you can see speckles here? And speckles all throughout the chest here. Those are considered like lung markings where it's kind of speckledy. But see how black it is here? I mean, it looks that way over here to me too because of the way this x-ray is. But a pneumothorax is basically where air is leaked out of the lung. So air shows up black on x-ray, tissue and things like that. And the reason we see like the speckles is because the bronchioles, the branches are there and we have airflow in them and they're a little bit of a substance. But we don't see the lung markings up here because of the pneumothorax. It's all air. So they're trying to drain that out to bring back the lung markings over there.
So an incision is made in the, okay.
Yes. Small incision, and then they kind of shove the tube in through it, and it's like a straw kind of. It sucks out whatever is needing to be drained out.
And then how do they get it out? Like, do they push it to the edge of the skin? And
yeah. Yeah, once it's in through the tissue, it's kind of like a hard end on it. It's not flimsy. They just push it through to where it needs to go, guide it in.
Yeah, to where it comes out the armpit. Like, do they push it against the skin and then cut that area to pull it out?
Yeah, when they pull it out, they just kind of go 1, 2, 3 and yank it out, and then hold pressure and let it get stitched up where the hole was. Yeah, it's not a fun sight to see that part. It's loosely in. I don't think they do an incision to hold that tube in place. So it's just tape, a little bit of tape around the area. The important thing for us, and on this slide I have it highlighted, is when we're doing an x-ray for a chest tube, even if it's not the reason for the exam, like this one says it's for a pneumothorax, if it was to drain out fluid or blood or something, when they put the chest tube in, they could collapse the lung and cause a pneumothorax. So we usually do a chest x-ray when they put a chest tube in to look and check to make sure they didn't have a pneumothorax, or by doing the procedure, they didn't cause the lung to collapse. So we usually do inspiration and expiration images. A pneumothorax basically is an area, and it could be a very small area, where the lung has like leaked out all its air in that area. So if air is leaking out and we tell them to take a deep breath in, that's going to expand the lungs and make them big. And we could cover up a pneumothorax when we do that. So we want inspiration and expiration, and I highlighted the wrong thing. Expiration is the one that is the most important when we're looking at a pneumothorax. So expiration images are like 100% needed, because if we do just inspiration, it's going to make the lungs big. Expiration is what they have to see. So you want to make sure you label them. This is something that doctors will sometimes order. They'll write a specific order for a chest x-ray to be done on expiration, but not always. Stop. So make sure when you're doing an x-ray for a chest tube, you don't dislodge the chest tube because it's barely hanging in there. Oh, it's not gonna let me until I clear the annotations. So chest tubes, number one thing with those is where they go in at and what chest x-rays are being looked for after we put a chest tube in. It's for a pneumothorax. So catheters that we put in, centrovenous pressure lines That's inserted into a vein and put in to measure pressure in the heart. So these are usually patients that are really, really sick, either for chemotherapy patients or patients in the ICU. You need to stop. Go lay down, Chapo. Central venous access catheters are venous access for patients that are going to be in the hospital for a long time. And you know, they put IVs in your arm sometimes when you go in the hospital. Those are venous access catheters, but they're temporary. They're only good to be used for like a day or two, maybe 3. Then they have to start a new one. So if you're going to be in the hospital for a long time, they're going to go into a very large vein, like in the neck or something, and put in a central venous line. So it's to administer drugs, lots of fluid being given in, blood analysis and transfusions, monitoring pressures. So all these reasons are reasons for putting in these lines. Lots of times it's mostly for medication, administering medication. So these are some names that you'll hear. I'm not going to test you on these names, but Hickman, Borovac, tunneled catheters, or Portacath is a common one, or a Mediport. They're usually inserted into a large major vein. So we used to put these in at the doctor's office I worked at, doing interventionals. So PICC line is probably a common one that you might have heard, a PICC, peripheral inserted central catheter. At most hospitals, if it's a big hospital, they have a PICC nurse or a team that goes around and inserts PICC lines. They do them bedside in the patient's room. We would put them in at the hospital with the fluoroscope so they could see them as they were putting in the line. They're very highly susceptible, I guess, to infections. So they have to be put in at a sterile environment area because they're going straight through the skin into the heart pretty much with that line. So it's a big sterile procedure when they're put in, and they check them immediately if you're in the hospital, because they're not doing it with fluoro always. They do it bedside, and then they have us come in and do an x-ray to check it. If you're doing it with fluoro, the doctor already knows it's in the right spot, but we usually still do chest x-rays after. So with these lines, they can be single, double, or multi-lumen. That just means the end of it could have one port to give medicine through, or 2 or 3, just depending on how many tubes they want to connect to it. But one going in, and however many they have on the edge out of it, on the outside. And that's just if they want to use one for flushing and one for certain medications like chemo drugs, and one for everything else like regular medicine. So we usually go into the subclavian vein or the intrajugular, and sometimes even in the femoral. I haven't seen very many in the femoral, usually in the neck, jugular, or subclavian. They go and they put it in at that spot. Stop. And they usually go through the vein into the superior vena cava, just above the opening to the heart, right where blood flow is fixing to go into the atrium of our heart. So we're gonna take an x-ray, usually a higher chest x-ray, so we can get the neck area where it's put in at, and follow that line all the way into where it stops. So they wanna make sure, number one, this area of our arch of our heart coming off has some veins that go up our neck, the carotids, and go into the brain. If they put that in and it goes the wrong way, we don't want a tube going up into the head. We want it to go down into the heart. So that's why they use fluoroscopy or take an x-ray to check it. So here's a picture of what we're talking about here. Some of this is inside the patient and some of this is outside the patient. So we go in through the subclavian, down the arch to right above the atrium of the heart. Two different sites here. This is a very confusing picture. This is if they were coming through the subcutaneous. This one's if they were coming through the subclavian. So this is 2 different methods shown in one picture. Tunneled around. This is what it looks like on an x-ray. So this piece here is outside the patient. This big plastic piece is laying on the top of the chest of the patient. That's where they're gonna administer the drugs and stuff. Then it goes through and it stops right here, right above the atrium of the heart. I can actually see the bifurcation of the lungs better on this guy too. See the trachea coming down, and then it splits right there. There's the little V. Again, that takes a long time to get used to. Looking at x-rays to see that. I'm not going to ask you guys yet. Wait till your chest and abdomen class to have to pick that area out. But just know where a PICC line or any of these lines, most of them are all going to go to the same area. We're going to talk about one in a minute that goes to measure the pressure of the heart. It's a little different. So we do a chest x-ray for a line placement. These are also stat. They want them like immediately after they put the line in to check for the placement. So we do lots and lots of portables at their bed to check for these lines. 2 to 3 centimeters above the right atrium. So here's a little one. This one's not as big as the other one. Still stopping right here by the right atrium. Looks like they have some other tubing here and had some surgery too. I don't see their bifurcation as good. I see the trachea, but I don't see the bifurcation hardly, but they look like they have a tip right there. Very hard to see on the way this one is. It's kind of gray. These lines sometimes are hard to pick out the end, especially if they have lots of other things crossing over. If they have EKG leads in the way, we want to move them out of the way. Another type is a Swan-Ganz catheter. This one is specifically to measure the pulmonary arterial pressure. So it goes to the left ventricle. And these are all, the one we just looked at was on page 183. Swan-Ganz is, I think it's on page 184. There's a picture of it going into the heart on 185. So we go through the same way, but this catheter has an electrode or a special monitor at the end of the tip of the catheter to measure the pressure. And these are going to be on patients in the ICU because those nurses have like a computer video and a monitor to monitor the patient's vitals from the outside at the desk. Sometimes they have a desk right outside the room that the patient's watching, the nurse is watching them. So the left ventricle is where the pressure is the most when the heart pumps. So it's trying to make sure everything's good with their patient. So they're measuring their pressure. Left side of the heart. Here's that picture from the book where the catheter is going through all the way down into the heart and then stopping. Ooh, this one shows it through the left ventricle all the way to the lung for pressure in the lungs. So they put a balloon down and measure it. This is done all with fluoroscopy usually to get it to go there so they can make sure they're in the right spot. So remember, the heart is pumping blood into the lungs to get oxygen, so that's the path it's flowing into the pulmonary vein over here to the lung to get that pressure. So we always go in and take an x-ray after this to make sure it's in the right spot. We don't need to diagnose it. We tell our doctor we've done this stat x-ray to check for the line placement, and he's the one who says if it's good or bad. And usually those patients get an x-ray every morning just to check their lungs and make sure all their things are in the right spot and nothing has moved. So we don't interpret images, we don't diagnose, we just alert the radiologist or the physician. So if we know what we're looking at and it's bad, if we see a line going up into the brain area, we may want to get on the phone and call the doctor, look at the x-ray I just took, so that we can alert them for the patient's benefit. We don't want them putting medicine into it or anything until it's in the right spot. Vital signs are going to be important for us to know. So if we go into a patient's room and we see that their blood pressure is like sky high, we might not want to do the x-ray right then. We might want the nurse to get them some medication, check on them, make sure everything's okay before we do the x-ray. If they're dropping while we're in there doing the x-ray, we can kind of notice some change in their face, temperature, sweating, stuff going on. They might be about to faint on you. You want to be able to pick up on these key things with vitals. And we also are going to make sure we know oxygen. We can't take on and off supposed to not without the doctor or nurse doing it for us. If they're on oxygen, when we pick them up from a room, we keep them on it throughout the transport the whole time. And then as far as appearance on commonly chest tubes and intratracheal tubes and central venous lines, you just want to know where they need to be. So chest tubes are going to be random depending on the area. So with chest tubes, there's no specific area. Endotracheal tubes is into the trachea, so about 2 to 3 centimeters above the carina. And central venous lines are going to go into the heart, right above the right atrium of the heart, 2 to 3 centimeters. Yes, that is that chapter. That was a lot today on that chapter. We got one more chapter to do too, guys. Trying to think, what time is it? It's 9:30, okay. Stop share. Let me look at this next section. Okay. Oh. So it's infection control. I have a video. You guys need a break? Stop, Chapo.
Yes.
All right. So let's come back. Why's my computer not charging? It's 9:32 now, so let's come back at 45.
I have a question.
Uh-huh.
So I started getting sick over the weekend. Am I still able to come to school?
So what they told us, for some reason my mouse is frozen over here. I can't get back to my Zoom. It's self-regulation. Who's saying that? Who's sick? Or
Caitlin.
not? Caitlin, okay. If you feel that you have symptoms, don't come if you have a fever or something. Not even if it's COVID. This is just general if you have a cold or a flu. It's just your own self-regulation. So we don't have to do those 5 or 6 questions anymore for COVID that they were making us do last month. We just have to take your temperature. So if you don't feel well, don't come. It will be broadcasted, the lecture part tomorrow on Kaiser Live, because at the school I just took up through Kaiser Live. So if you don't come for some reason, if you're sick or something, just send me a message in the morning and I'll hopefully make sure I pay more attention on the Kaiser Live than I normally do when everybody's present.
Okay. I'm pretty sure it's just a sinus infection because I get them like around this time every year, and it just always drains. So I'm pretty sure that's what it is. But my husband keeps telling me to go to the doctor because he can't risk getting sick because of everything in the military. So I should be going today, hopefully.
Okay. Yeah, they won't let you, I mean, unless you go to one of those places that does it in a few hours, but I'm pretty sure it's probably not, hopefully anyway, cross our fingers.
Yeah, me too.
All right, see you guys at 9:45. I have a lot of questions I'm reading right now. Elizabeth asked about what we're quizzed on tomorrow. We'll talk about it. We'll review. All right, how about you need to go lay down. You have been out there and you've All right, everybody ready? Back. So I put a little note, kind of summarize what I think the most important things are from last chapter, ranges on all the vitals and what they could mean, high versus low, different equipment that we're going to use for them, like the blood pressure cuff, the sphygmomanometer, the stethoscope, the types of tubes that are going to be inserted, the chest tube versus the PICC lines, the oxygen delivery methods, so the oxy tent, the face mask, the nasal cannula, so those things. Oh, Jessica, is it gonna let you hear us? It's breaking up for that part.
Did you say?
I can hear.
Okay.
Quick question, are we doing interviews today?
Was that on the syllabus for today?
I think so.
Not on the syllabus, but I think a couple weeks ago you said it was going to be today.
It is going to be this week. I just don't remember Miss Osteen's what day her class was able to. Let me see if I can message her real quick. I wanted it to be, I can't remember what day she said she could do it.
Miss Love, you said you did some notes or something?
Yeah, in the chat, I just put a little thing. Can you see it off to the side, chapter 15?
Okay. Chapter 15. Okay. I see it.
I think I already sent her the link to give them. I know she's at the school today, but some of her students were going to come on the live. You're right. We'll see what she says. Okay, so next chapter 16, not 16. Ooh, it's cardiac monitoring. We don't need that. Chapter 17, infection control. So I have a video, but I think I'm gonna wait till we get to that part in the slideshow to share it. So this is a very important chapter for everyone that's never been in the healthcare. We wanna make sure we're always maintaining good hygiene. The book has these as the objectives of the chapter. Make sure we know terminology related to infection control. There's 4 types of infectious agents. Hold on, Miss Osteen's calling me. Hey. So did I. One of my students just asked me about it. So you want to do it on Wednesday? Will they be able to? Okay, thanks. No problem. All right, bye. Let's say 9 o'clock because that way they'll be done with their quiz. Yep. Thank you. Bye-bye. So 9 o'clock Wednesday. So there's 4 different infectious agents that we're going to talk about. The steps involved in the establishment of infection control, that's going to be the main important thing for test purposes. Spread of disease, the chain of infection, so those kind of go together. Make this big so I don't have to keep looking. Standard precautions, transmission-based precautions. So those are going to be the video that I have for you, and how to properly prevent the spread of these infections, the technique that we use to keep us safe. So this is the beginning of the chapter. Again, like the RT, the radiation chapter, we're talking about in all those people in history that invented things. We don't need to worry about it too much. You do want to know about the history. Before, a long time ago, we didn't know there was microorganisms that caused disease and bacteria, and we didn't have a method for controlling the spread of infection. So people were dying in the plague and things like that. So it's kind of the history part, but we are hopefully stopping the spread of disease with using the things we know now from the history. So infection is basically the establishment and growth of a microorganism in a host, resulting from injury to that host. So it's caused by pathogens. So once the pathogens come in, their main thing is to multiply and cause damage. And they can secrete exotoxins, and those are what's going to cause side effects that make us sick. Go lay down. Types of pathogens we could have: bacteria, virus, fungus, and parasites. So 4 types of pathogens. Bacteria are microscopic, so that's why they send things to the lab for a check, see if you have a bacteria infection. They have a host. They have to have something that they can keep growing on. And they're going to look like, under microscopic, they're classified in spheres or rods. They do test them in the lab by the staining, the Gram staining test, to classify the bacteria. Not important. We're not going to test you on that. Don't write that down. You don't have to worry about that. So it has the RNA and the DNA. So bacteria infections are the ones that we use antibiotics to kill. We just have to match the right thing with it. They're highly resistant to the external environment, so they can live dormant, and they are hard to kill. Viruses, on the other hand, are not very well living outside of its cell. They still attach to a host. They have their own genetic information, so they can check and see what type of virus it is. And they are not affected by antibiotics. So that's why they say if you have a virus, just let it run its course. You can't get antibiotics to treat it. So they can lie dormant and then manifest into an illness. So like HIV, I think, can do that. That's a virus that lays dormant and comes out later. Herpes does that too. Fungi infections. So these are a larger size spore when they look at them under the microscope. 2 types, yeast and mold fungus. 4 different classifications. We're not going to test you on all that. And then we have protozoa, or parasitic. They're not plant or animal. They're larger than a bacteria. They live at the expense of its host. So they can't live without a host. They can ingest food particles, and some have their own digestive systems. These are really gross parasites. This is where C. diff comes into play. It's a type of parasite in the body. It's probably the most one that's the bad one. Flagellum, that's another one I've heard of. Cilia. We're not going to test you on the types of parasite for protozoa. So here's the things that have to happen for an infectious disease to become an infectious disease. Has to have an encounter, has to have an entryway, that it's going to spread and multiply, do damage, and have some kind of outcome. Go lay down. He still wants to go back outside. So with the encounter, that's where it comes in contact with us, the host. So whether we touch a doorknob that has it, or a tabletop, or somebody coughs and it gets spread onto us, that's the encounter. Then it needs an entry. So it could be through breathing, ingestion. Or penetration. It could be from a needle stick. You could get accidentally needle stick and spread infection that way. Then after that, it's going to spread. And our immune system, hopefully, will fight it off and get rid of it. So multiplication, that's if you don't do anything, it's going to multiply. And it has an intubation period usually, where it's going to sit dormant and not let you know that you have it yet. So damage can be direct or indirect, depending on your body, your cell, how much of the bacteria, what it did to you. Hopefully you get rid of it and don't have any damage at all. The outcome is hopefully what we want is that we, the host or our body, gains control over it and gets rid of it. Or the infection can overcome you and the disease will cause death. Or you can live in a symbolic state and compromise to live together. So there's our 3 different outcomes that could happen. We have this little circle. This is a chain of infection circle. You want to write this down on your test or something and know it. That the host has the infectious organism. Somehow it has a mode of transportation into the body, and then it's held into a reservoir. So if you break any link in the chain, then this infection is going to no longer be continued to go and be spread. The ways that we transmit, these are going to be important for the infection methods that we're going to try to prevent when we're in the hospital. Air, that's an airborne. Droplet, that's through the particles. So that's with COVID, it was a big debate, and I don't know if they've ever come to a conclusion. Is it an airborne precaution or a droplet precaution? 2 different things different that we need to do with those, depending on what they are. Contact just means you have to touch it, come in contact with it. Those are our 3 main disease transmissions. Can be exogenous or endogenous, and then vector versus fomite. I hope we have a slide talking about these on their own in just a minute.
What was the difference in exo and endo?
So from the outside or from the inside transmission? Yep. Nosocomial infection just means that it happened in the hospital. While you were in the hospital, you got an infection. So hospital-acquired infections are what hospitals do not want to happen. UTI, it was, at the last I heard, was the #1 nosocomial infection, a urinary tract infection from catheters. And we have one more. This is iatrogenic infection. This is from the care of the practitioner. So the doctor doing surgery accidentally contaminated or caused the infection from the surgery. So if you get an infection after surgery, like MRSA or a staph infection, then it was considered an iatrogenic infection because it was because of the care of the practitioner. I guess it could still be a nosocomial at the same time. Yes.
Any treatment that comes from the infection from the hospital or whatever, do they pay for it, or do you have to pay?
Usually you have to pay still, unless you sue them and win.
Yeah, okay.
Because there's a risk explained to you with every procedure, even when you get a catheter in. That's a risk. Yeah, good question. So we have compromised patients, immunocompromised patients. They're going to be highly susceptible to getting these nosocomial infections. Medical personnel are going to play a role into it. If you're sick and come to work, you can make the patient sick. Or if you're not doing proper standard precautions or cleaning right or doing the procedure properly, you could cause an infection. Patient flora, that's their own body bacteria that they have already. So maybe they were already going to get a UTI before they came into the hospital, but it just so happened they got it while they were there. The hospital having a contaminated care environment. So we have people that go around and clean and things like that to help prevent that. Interventional procedures, these are procedures that we usually consider where we are opening a wound or going in through the skin somehow. Those are highly susceptible to having staph infections and things. And then we're going to talk about the blood-borne pathogen type of disease that could spread. So encouraging nosocomial infections. Again, this is just focusing on the things that could happen in the hospital. If the hospital doesn't clean the room properly before the next patient comes in, especially in the ER, you have a lot of turnover. That bed will probably have that up one room, 4 or 5 patients in a 24-hour period in the same room. So they have to come in and clean the sheets, wipe the bed down, sanitize everything before the next patient comes in. Going in through therapies like dialysis treatments and things like that people come in for cancer patients. The equipment that's being used on them, contamination during the procedure. We have lots of areas in X-ray where we could cause infections. Putting in those lines and tubes, catheters, all of those are going into the patient. If they're not properly sterilized and clean while we're doing that procedure, we could be putting in bacteria into the patient. So age plays a big factor. Young people, older people are going to be more susceptible, babies and things like that. Their hereditary, their genetics, their nutritional status, how healthy are they, stress level, not having a lot of exercise in their life because exercise helps build up good things, adequate rest, not getting rest, their personal habits, their health history, not having proper defense mechanism already into their body. It's all going to be factored in to if they could get more susceptible to getting them. So with the bloodborne pathogens, so you guys are doing that course, so you'll learn in depth about these more, but anything that's in the blood that could spread infection, these are considered healthcare acquired infections. And usually we want to protect ourselves from them, so that's why we get the vaccines that we can get to protect ourselves. So we have the HIV virus and the hepatitis B virus that we have to be careful of. So it's been a long time since it's been in the news, HIV and AIDS. Symptoms of it could be severe weight loss, muscle joint pain, swelling, night sweats, and they could remain dormant for many, many years. They have come a long way with treatment and helping these patients to be able to live for a long time once they've been diagnosed. Most of them are going to die from a lung infection because their body's not going to be able to fight off the infection, and that's usually what happens in HIV patients. They get some kind of infection that takes over and their body can't fight it off. Sometimes you could be asymptomatic for 10 years and not test positive. So it's crazy. So liver issues, liver function tests would be done. Again, if they start having jaundice, yellowing, that could be a sign their liver's not working. Whoops, sorry, skipped into the hepatitis is liver related, I forgot. So we have patients that are alcoholics that get jaundice and hepatitis. There's different forms of hepatitis. Again, 2 to 6 weeks after they develop symptoms, they can show positive test results and they could recover. Some people just take medication for the rest of their lives. There'll be hepatitis C patients who will tell you I have hepatitis C. They just take medication for it. So our body is crazily amazing. We have all these things that help us to fight off infections and things. We have different things that we can help us to keep from getting infections too. And the number one thing being hand washing. So that's our number one defense against infections is washing our hands. We have mechanical things, chemical things, cellular processes in the body, but bacterial agents like the hand sanitizers and things that we can clean ourselves with. There's also vaccines and immunizations that we get to help prevent us from getting these infections. So the number one thing in the hospital we use is standard precautions. Basically that means that we treat everybody as being contagious, and we are going to protect ourselves from any type of contact with the body fluid or substances. So we will wear gloves and add extra protections when needed, like a gown over our clothing, eye covering goggles, the shoe coverings that they have to keep us from having any contact with any blood or body fluid from the patients. This is our transmission-based precautions that you need to know. Airborne, droplet, and contact. So airborne meaning that if you breathe in the same air the patient's breathing out and they have something and you breathe it in, you could get it. Droplet means that it has to be the droplet that you're breathing in your nose or mouth, that they cough and a droplet's in the air and we breathe it in. And then contact precautions is like the least, so airborne's like the smallest, tiniest particle, to where you have to have super protection against, and then droplets kind of in the middle, and then contact is another one that if you come in contact with it, so a C. diff patient, that's a bacteria that's in, it causes severe diarrhea. If you come in contact with that bacteria while you're moving your x-ray plate under them and you didn't know it and they had some leftover bacteria on the bed, you touch it and then later touch your face or something, you could get C. diff from that interaction. So in certain situations, we protect ourselves with different equipment to prevent from coming in contact or having droplet or airborne bacteria to get into us. Is that really all this thing has for that? Okay, it's got more later. I thought I saw more. I looked at this earlier. So what we do, we call this asepsis, when we are preventing ourselves from getting this bacteria. So we have surgical and medical asepsis, and they're a little different depending on if you're going in to do a surgery on a patient, you want an extra wash, where medical is just general hand washing. So there's two different kind of, depending on the situations. So with our hand washing for a surgery, you have special soap that we use, and we clean under the fingernails and scrub for like 3 minutes or so before we go in and do the procedure if we're operating on a patient. If we're just going in to do an x-ray on a patient, we're gonna do the whole hand washing with just regular soap and rubbing it between our hands. We're not using the whole fingernail scrubber and getting all the bacteria off our hands with a special soap cleaner. So that's the difference between surgical and the medical hand washing of cleaning our hands. During surgeries, we act a little different in the whole way we set up our room and everything than just having a medical asepsis when we're doing a OR type procedure in our fluoro room where we're just doing a lumbar puncture versus going in and doing a whole hip surgery. There's going to be two different types of room setups, and we'll talk about those in a minute. In this whole disinfectant area, we will be doing autoclave, where we sterilize instruments and we reuse them. So if you're working somewhere that causes you to have to autoclave, it's probably going to be a place where you're doing surgery, where you're having to sterilize the equipment, like the clamps and the scalpels. Sometimes they do disposables. Sometimes it's the tweezers and things like that that you'll clean and reuse. And we have different bacterial disinfectants that we use. The wipes that we use in the lab are a type of disinfectant that gets rid of bacteria and kills them. So when we have this sterilization happen, that kills everything. So the autoclave is a machine that we put the equipment in, and it uses like a steam heat to kill the bacteria. You can also use UV light. And that's something that companies now are coming around and doing to the buildings to kill bacteria, to say they've been sterilized for COVID cleaning. You can also get a UV light for your air conditioning unit to kill bacteria in the house and fungus and molds. So with standard precautions, this is what we pretty much consider with every single patient, that we're gonna do hand washing, gloving, and anything that we put on us is considered PPE, personal protective equipment. That includes the gloves, a gown, a mask, shoe coverings that we wear, personal protective equipment. We're going to talk about needle recapping to prevent us from getting a needle stick, and if we have a spill. So if we were in the class, we usually put this stuff on you to mimic bacteria, and it glows under a black light. And then we have you go wash your hands and see if you get it all off. And it's crazy. Nobody hardly ever comes back with it all off. It usually gets stuck under the fingernails and in the little wrinkles of your knuckles. So you've got to be very, very thorough. I have had one person, I think they worked in a lab before, who came back with almost nothing on their hands after it. But we come in contact with everything you don't want to think about too much during a daily basis, especially when you're in the hospital. And the rule is that we wash before and after every single patient. And now they have made hand sanitizer be the equivalent of hand washing. I still feel like hand washing is the best. So there's a whole section in the book on how to properly wash your hands. And it seems like it should be common sense, but there was actually, I think it was Dr. Oz or someone came on the news and showed how to properly wash your hands too, did a little video. So you do want to do the proper way to actually get rid of all the bacteria. So it should be second nature in life. It is funny how you start to do this just generally now. You don't want the water to drip this way down your arm. You want it to drip off your fingers down. So you want to wash and scrub really good in between your creases of your fingers. If you have jewelry on, you want to take it off because that harbors bacteria. No fake fingernails, we've talked about that. And then scrub around the nail beds as you're washing. And it should be a full singing happy birthday. Is that the little tip that they give out for hand washing?
No, you sing your ABCs.
Oh, ABCs.
But one question when you were talking about putting hand sanitizer being the equivalent of hand washing, if when they inspect us or whatever, we need to do both, right? Or
One or the other. So the rule is that you can sanitize in and out and it's okay unless it's visibly soiled. If you touch something and you have something on you, then you have to wash hands. And I think they say, I think it's 3 times or 4 times for sanitizing, and then you should wash your hands. It's not in our book though. I guess it's just picture and washing, but wet your hands, soap your hands, then do the scrubbing for the ABCs, length of time, and then rinsing with the fingers down and then drying, and then don't touch the doorknob when you leave the bathroom because the doorknob's dirty. MA program used to go around and do swabs for the building and grow bacteria and see how bad it was. The bathroom was bad. The time clock where we punched in is bad. The elevators was really bad. All these things had lots of bacteria on them. With now, I think Myrna goes around and cleans like every hour, the elevator, so it should be good now. So when we're talking about these precautions, we use what we call standard precautions unless we know they have a certain thing that's transmitted. And we have transmission-based precautions for these other diseases. So if we know a patient has a certain organism in them, we're going to put some extra care in to not get that. So we would use these with standard precautions, these extra types of precautions. So if you're on a floor of a hospital where they're doing organ transplant, they will do immunocompromised patients because we don't want to give them our sickness. So they would do like a reverse isolation precaution. That's not on here, but just know sometimes it's for the patient's protection, not just because they have something that they can give to us. We're not going to get told their disease. They're just going to get a sign on their door that says airborne, droplet, or contact. That lets us know we need to use the proper protective equipment, that PPE that's added for that pathology. So for you guys, we're going to let you know the different types of precautions and what the extra equipment is, and that's what you'll be tested on. So for us, we always use the gowns, gloves, mask when needed. And here's where we know what's needed. So extra gloving is not going to be 100%. I don't like this picture for this. Gosh, let me just show you my video in a minute. Let me see what they got in the book. They don't have it on here for the specifics I want you to know. On page 205, we're going to highlight some things and then I'll watch the video. The video is for nursing students, but I like it because it gives you guys a clue onto what pathology infections go with each precaution, because they're not going to tell us what the patient has normally. Airborne precautions, like I said, is aerosol that's coming through the air. So TB, tuberculosis, your book has listed for that. Chickenpox is listed too. The measles, these are things that can come through the air, and if we breathe them in, we're going to get it. A regular surgical mask will not protect you against airborne precautions. The mask that they have made everybody make and wear, the fabric mask that everybody wants to look cute and get their favorite football team or whatever on, are not going to protect you against airborne precautions. So that's the debate that came out with COVID, that it was airborne at first. And only thing that can protect you against airborne precautions is an N95 respirator mask. Doesn't say it in this book. I don't know why. Stop. Go lay down. So airborne precautions requires extra special surgical mask with filters. It does say that. It doesn't call it an N95 mask. The patient should also be put in a room. It's called a negative air pressure room. Wait, so how do you breathe? Go lay down. So these are the type of rooms that patients with COVID get, just like a TB patient, just like a chickenpox patient, because it's going to keep that bacteria that's airborne from the rest of the hospital from circulating through the air system and spreading it. So if you have a patient that has TB, tuberculosis, that was probably the #1 thing before COVID that we would protect against with airborne precautions. I never thought about chickenpox, but we do put chickenpox patients in those rooms too. They don't come out of their room. They stay in there because we do not want them spreading it to the rest of the hospital or patients. If they do come out of the room, then they wear a regular surgery mask because it keeps the droplets inside the mask. So sometimes they will bring the TB patients down to us to do an x-ray on if we can't go to them with the portable. Usually it's a CT or something like that. The next one is droplet precautions, and that's for patients that have things that would be spreadable through bigger size droplets. Airborne is very small particles. So rubella, mumps, the flu. So if you have the flu, you're going to be put on droplet precautions in the hospital. And this is things that are going to come through the nose or the mouth, breathing in or something if they cough on you and they have it. So we're going to wear a surgery mask type in that room. So those are the blue or the yellow ear loop mask. Usually the hospital will have a sign on the door and a cart outside the room with the right equipment for that patient for you to wear. And then the last one is contact. This is for a patient that's just got some kind of virus or something like staph infection or the hepatitis infections. So we're going to wear a gown and gloves. And sometimes people wear a mask in those rooms too, just to protect. And you want to not breathe in any air that's in there, but it's not required. But everything with those patients, if they have somebody that has the same disease as them, they can share a room. Whereas with any of these, I guess, actually, TB patients can be with other TB patients. But they don't have to be in the special negative air pressure room. They're just in a regular patient room. There is a contact precautions technique. I guess that's what this slide was trying to show us about it. It's pictured on 207. Normally, we want 2 techs to go into the room, one that deals with touching the patient and one that deals with touching the equipment. So that way, the person that's touching the equipment is clean, and the person that's going and putting the board behind the patient is kind of the dirty tech, clean tech, dirty tech, we call it. So that way, it's easier when you leave that room to clean everything and wipe things down. Everything that you take off afterwards goes into that patient's room's garbage, so you're not spreading that infection outside. So you don't want to wear those gloves that you just used on that patient and go down the hallway pushing the portable and spreading that bacteria to the next patient. So you can help each other tie each other's gowns up. The yellow gowns that are in the picture here are actually washable and reusable. Sometimes the hospital has those types, sometimes they have throwaways. So it just depends. The ones we have at the school are throwaways. So tomorrow in class, I'll show you that, and we'll talk about the gowning and glove and teaming up with 2 people to do the clean tech, dirty tech. And that's for contact precautions. All right, let's watch the video. Let me see what else we got before we watch the video. Yeah, that's the conclusion, so. I gotta stop share to get to it, so. Yep, Sarah's got it. If you have anything that you can see dirty on your hands, you have to wash them. Still showing the slideshow, sorry guys. Let me close that first. And again, I said this lady is a nurse. She's teaching it for the NCLEX exam for nursing, but this is some of the questions that radiography exam might have on it too, similar to what she's talking about. Just not as in-depth on the treatment part, just the types of bacteria and the precautions for you guys. Can you see it?
Yeah.
Can
Yes.
you hear it?
It's kind of hard to hear.
Lagging.
Kinda, no. She's freezing up.
Mm.
Yeah, she's lagging pretty bad.
Okay. Then I will just post this link into our board, our class. Yeah, Nurse Sarah.